So welcome to another edition, if you will, of Beyond the Headlines, Making Childbirth Safer. I am so pleased that we have with us a very special guest today. Dr. Lisa Hollier is the current president of the American College of Obstetricians and Gynecologists, or ACOG as we call it for short. She is a board-certified OBGYN and specialist in maternal fetal medicine. So brings a wealth of clinical experience as well as leadership, many years of leadership experience within ACOG. For those who are watching who aren't familiar with ACOG, it is a membership organization that represents the physicians of this country, the OBGYNs of this country who work in women's health. It really is representing the professional and socioeconomic interests of its members through continuing medical education, practice, research, and advocacy. So Dr. Hollier, welcome and thank you so much for joining us today.
Thank you so very much for having me. I'm just delighted to be here with you.
So we're going to talk about a really somewhat disturbing article that came out in USA Today on September 20th. And it was focused on what hospitals are not doing to save mothers. It's part of a whole series that we've been focusing on for a couple of years actually in this country on the maternal mortality and morbidity rate. So ACOG is one of the Preeclampsia Foundation's partners in advancing legislation that would support the creation of Maternal Mortality Review Committees, or MMRCs, in all the states of the country, across the country. And yet, one of the criticisms that this article levies is that MMRCs are ignoring the provider errors or provider practices where there are opportunities for improvement. And they feel, the article says that they're ignoring those in their reports. So as an example, there's a quote that says, "The panel members were assigned only to review maternal deaths, tabulate causes, and determine contributing factors, not to look at the quality of medical care." So is that true? Talk to me a little bit from your perspective, because you serve on the Texas MMRC, so you've got a couple of different important perspectives here.
Right. So I'll start with the perspective as chair of the Texas Maternal Mortality Review Committee. The work that we do is incredibly important in understanding all of the factors that contribute to an individual maternal death. So as the article mentions, we do study the causes and the contributing factors. When we're looking at contributing factors, we look at a variety of different types of factors, and they absolutely include provider factors. We are looking very closely at opportunities for improvement in a number of different areas, whether it's the timing of a specific diagnosis or when the appropriate treatment is initiated. We're looking not just at the provider level, but we also look at the facility level. So were there opportunities in the way the staff at the facility were managing a particular situation? And then we're looking across systems as well. This really does give us a much broader picture of all of the integration within a particular woman's healthcare experience for her pregnancy and potentially for her delivery as well. And then finally, we're looking out at community factors and the role that community factors might have played in a particular maternal death. So in in my experience and the experience of many other committees who are doing this work, we really do look very closely at the detailed medical records and look very closely for opportunities to improve care at a number of different levels, including the provider level.
Mhm. And who tends to sit on these MMRC boards or panels? Is it all providers and nurses? Who comprises the panels?
The individual membership of the panels can vary from state to state. In Texas, we have a multidisciplinary committee that includes OBGYN physicians, maternal fetal medicine specialists, a psychiatrist, a social worker. We have epidemiologists, we have labor and delivery nurses, we have a midwife, we have someone who specializes in health disparity research. So there are a number of different individuals who contribute their expertise as we're talking about the cases, and that has been incredibly helpful to us to have a much fuller picture, a better understanding of what's really happening from a lot of different perspectives.
Is there an opportunity to have maybe not patients or family members who have themselves suffered a loss, but maybe who have had near misses or who have experienced healthcare as a laboring mom and a delivering mom, who might provide some perspective to those MMRCs? Does that happen in any of the states, to your knowledge?
We have a member from the community on our task force, but at the current time, she also happens to be a nurse. I think there's an opportunity for review committees to include public members. My experience in working with public members, whether it's on the Council for Patient Safety or other groups, has been very, very positive. And I'll call you out specifically. You've been absolutely terrific to work with and provide incredible insight. So I think there is an opportunity to bring in the patient perspective as well.
Because certainly one of the criticisms that the article has is that if those panels are comprised of doctors and nurses, that they're not going to be honest and reflective about where doctors and nurses have perhaps failed the women. And of course, they're not going to ever be on a panel where they're talking about a case that they themselves participated in. How does a physician who is, obviously feels perhaps some allegiance with their colleagues, how can they step back and look at what other doctors have done and perhaps identify where there were preventability factors?
All of us sincerely just want to do the very best work we can for all of the women that we take care of every day. And in my experience, the clinicians that I've worked with have not hesitated to look at the care, and they really do step back and say, gosh, this does not meet what we believe is best practice, and we haven't shied away from doing that. That's part of continuous quality improvement, and I think that really being able to look at this entire process through that quality lens to identify those opportunities objectively and deal with them, use the opportunities that we identify to develop appropriate interventions, actionable things that we can put into place that really save women's lives. That's what we all want, and in my experience, that's what we've been able to do.
Is there evidence that has worked? Are we far enough along in this process that we have seen improved outcomes in any states that are doing this?
I think when we want to look at the evidence in going from review to action and seeing those results on maternal mortality, I think we look to California. Through California's Maternal Mortality Review, they identified a number of contributing factors to maternal mortality in their state. So they identified that there were delays in diagnosis and delays in appropriate treatment in hemorrhage, for example. So what the state did then was work with their perinatal collaborative to develop an implementation plan, to develop a bundle, a collection or toolkit of different components that can be put into place at a hospital. And when those components are put into place, they've seen significant improvements. So when we look at the improvement in California, the implementation of that hemorrhage toolkit or hemorrhage bundle, as we more often call them now, has resulted in significantly fewer women with hemorrhage complications overall. And you can look at their maternal mortality rates after the implementation of their hemorrhage and hypertension bundles. And they've seen significant declines in maternal mortality, and they've also seen a narrowing in the gap for African American women and Caucasian women. And both of those things together are incredibly important, and I think provide us good evidence that understanding these specific opportunities, developing interventions based on those identified opportunities, and implementing them can really make a change.
I know one of the, it's sort of, people chuckle, but Dr. Elliot Main, who heads that California initiative, has talked about the fact that when we talk about preeclampsia and hypertension and pregnancy, that clearly one of the things that has come out of that MMRC is the quote that he often says, treat the damn pressures, and has really driven this focus on the need to treat hypertension in pregnancy, that letting women have their blood pressures get too high in pregnancy is life-threatening. It is absolutely life-threatening. And that's an example of where, that's clearly an area that doctors and nurses can rally around, that very specific practice in the hospital setting and not let a woman's blood pressure get too high. So that's certainly probably further evidence of what you're talking about.
Absolutely.
So one of the things that the article talks about is, and spends a lot of space talking about, is really what are pregnancy-associated deaths. So women who die from suicide or drug addiction or car accidents who happen to be pregnant at the time often end up in these reports. And that's really seen as a pregnancy-associated death rather than a pregnancy-related death. It's not because she was pregnant that those things happened. She just happened to be pregnant while those causes of death occurred. Why does that data end up in the MMRC?
Well, I'll speak from our Texas experience. When we are trying to identify all of the maternal deaths that happen within a specific time period, we use a year to identify all of our maternal deaths. And in that process of identification, we are basically starting with everyone who died within a year of the end of pregnancy. And so what that data gives you is both pregnancy-related deaths and pregnancy-associated deaths, because we're just starting with deaths within a specific time period. It's only through then the detailed reviews of the medical records that we're able to make a determination about the relatedness. If this woman had not been pregnant, would she have died? And so we're able to, in doing those detailed reviews, distill down the women and then separate them into pregnancy-related deaths and pregnancy-associated but not related deaths. And then there's some where we just can't tell for sure. And so we end up with about 3 different categories of death. And because we've really invested and we believe that there's valuable information in all of these deaths, we do report information based on all the deaths.
So, Dr. Hollier, there are, about 40,000 OB/GYNs in this country. And as you said earlier, every one of them has the intention of do no harm. Every one of them has the intention for supporting their women and the babies in successful outcomes. So the intention is absolutely, we'll start from an assumption of absolutely the most honorable intentions. But there is a lot of information that physicians have to stay on top of. There are new medications, there are new procedures, there are new health system processes to deal with. And the reality is that they're not all current with what is the best way to diagnose and treat hypertension in pregnancy, as an example. And I would guess that the physicians that read these articles and get really annoyed by them, or the ones who are engaged in MMRCs or other quality improvement initiatives, they're probably not the physicians who have the struggles with treating, diagnosing, and doing the right thing. It's probably the ones who maybe don't have this on their radar. And I guess the question to you as president of ACOG is, how do we reach the masses? How do we ensure that all OB/GYNs are doing the right thing? What's the message to them?
The way that we're going to be successful, I think, is to really use a lot of different strategies, because people take in information in different ways. ACOG is exploring a lot of newer strategies to engage our members and really convey all of this important new clinical information that's coming out every day. So we have a number of different communication strategies and outreach strategies for our clinical information. And we are undergoing, as part of our ACOG 2020 strategic plan, looking at a variety of different modalities to enhance that engagement with providers. So looking
Can you try just a couple examples just to kind of...
Yeah. Oh, sure. So we currently do a lot of push notifications through email with the latest clinical information. We have those that go out to people every day. We have really wonderful education offerings. We've just finished sort of the fall series of the annual district meetings, where a lot of education happens. We have several freestanding courses that we're still offering, again, to provide education. We have information that's readily available on our website. All of our clinical guidance is readily available, and we've recently reorganized it and made it much easier to find the clinical guidance that people are looking for. We're also investigating newer technologies, podcasts, webcasts, things like that, to again, facilitate engagement. And then we're looking at some really innovative solutions, putting this clinical support into the hands of the providers at the time they're actually seeing patients. So using the electronic medical record system to link with ACOG clinical guidance, so that in real time an OB/GYN physician can see a reminder and can act on that clinical reminder. So providing up to the minute timely education right at their fingertips. So we are really trying to look at a number of different ways to shorten the amount of time from new scientific information to implementation.
Is there anything patients can do to advocate for themselves and to support their providers being on top of the latest information?
I love it when my patients ask me questions. I think it's a great opportunity to have a discussion, and it's an opportunity for me sometimes to go to the books and find out if there is something new that a patient may have heard about that I wasn't aware of. So I think having that opportunity to have a really meaningful discussion between the patient and clinician is a great opportunity. I would recommend writing down your questions. Sometimes I know when I'm the patient going to the doctor, I get a bit flustered myself. And so I really like to have something that I can refer to for those questions. But just speak up. If you're not sure about something, ask about it. It's, it's, it's a great opportunity, again, to have a really meaningful discussion.
So there are some states that have not implemented MMRCs yet. We are trying to push this legislation over the finish line, if you will. There's going to be, I think, what many consider a very short window of opportunity to get HR 1318 and S 1112 to pass their respective houses. What is ACOG doing, and what can you recommend that we do?
I think this legislation is so important to provide support and infrastructure to states, particularly those who do not yet have a maternal mortality review process in place. This legislation can really make an important difference in the lives of women and in their families everywhere. ACOG is going to be having a fly-in. We're actually bringing in our junior fellow leadership and some of our other senior ACOG leaders to come to Washington, D.C., to be on the Hill, to be speaking out to ensure that we can achieve passage of this important legislation. What can all of us do? We can all connect with our members of Congress and let them know how incredibly important this legislation is to us and how strongly we want them to move this forward and pass this legislation. I think it really provides excellent support and infrastructure for state-based maternal mortality reviews and really can make an important difference.
So we will put a link in this video that will allow viewers to follow that link and find out how they can support this, because it really is a matter of call and contact your representatives. So one last thing in terms of the patient engagement piece, if a family does suffer a maternal loss, how can they ensure that their state reviews the case? And a corollary question to that is, if you could talk a little bit about the Joint Commission process, because the Joint Commission does have a link, which we'll include here as well, for ensuring that a family has an opportunity to report a matter that they feel may not have gotten the right attention.
The process may vary for the individual state-based maternal mortality reviews. Eleni, I don't really have additional detail to answer that question.
Okay.
I think it depends. There are some states, I believe, that allow that kind of direct reporting, but ours is all data-driven.
Okay. That might be a really worthy thing for us to advocate for, which is just a conduit, a communication conduit that a family can ensure, because the state, one of the issues with MMRCs is it's only as good as the data that's been collected
Right.
and the sources of information, medical records, administrative data, et cetera. And one of the things that we're advocating for is that there really be an opportunity for the family to provide a narrative of what happened from their perspective. There's often information that only the patient and her family have been privy to, if you will. They're sitting at the center of everything that's happening. So doing informant interviews or asking for a narrative from the family, and then giving an opportunity for the family to say, hey, has our case, is our case on your radar? Has this made its way through the medical examiner's office or wherever? I think that's a huge opportunity that we could talk some more about. But we are going to also include a link here because the Joint Commission does have a process for reporting complaints that patients may have if they're concerned about the care that they received. And while that's different than the MMRC process, it is a way to ensure that if you don't feel like you got the care that you should have gotten, there's a reporting process in place. The Joint Commission, for those who are watching who don't know, it's a not independent, not-for-profit organization that accredits and certifies something like 20,000 health centers around the country and organizations. So they're the ones who allow hospitals to operate as accredited hospitals, for instance. Anyway, we're going to close out this segment. I think one of the important messages that you've really shared with us is that patients absolutely have the right to advocate for themselves. And that's often easier said than done. It's very intimidating sometimes to walk into a doctor's office, and there's a power differential there between the patient and the provider. But we have included a couple of links here. Both the Preeclampsia Foundation has produced a patient bill of rights. We sort of call it that, but it's an interpretation of what the hypertension bundle is suggesting as best practices and how we as patients would experience those best practices. So we've included a link to that article. And then USA Today also produced tips for patients. So we'll provide that as well. Dr. Hollier, thank you so much, because I know this maternal mortality is one of your big platform messages. And I speak on behalf of all women who have suffered from preeclampsia-related hypertensive disorders of pregnancy when we say thank you for caring about moms and their babies who suffer from this condition. And I know it's also personal to you too. So do you want to just close us out with any comments or anything else that you'd like to share with us?
Thank you so much, Eleni. We really do have an incredible opportunity right now. Never before have I seen so many organizations, so many patient groups. Everyone is working together to end maternal mortality in this country. And I am so delighted to be working with everyone, and I truly believe that we can change this. We can reverse this terrible trend, and we can make the United States the safest place to have a baby. And I really look forward to doing that, to working with everyone to achieve that goal.
Thank you. Thank you for your service.
Thank you.
So that concludes another episode of Beyond the Headlines. Again, we're going to include some links below that can take you to some resources and materials that can help you be part of the solution. Again, I want to thank Dr. Lisa Hollier, the president of ACOG, and very influential physician in her home state of Texas, for joining us today. Thank you so much.